Okay, good afternoon, everyone, and good morning to our colleagues in the US. We're very happy today to have our 10th Pediatric Emergency Medicine series, which has been running since January, and today is going to be our 10th lecture series. We're going to have a very interesting topic, which is going to be on approach to congenital heart disease in emergency care setting, and will be facilitated by our two keynote speakers. I'll just give a brief introduction, but they'll then introduce themselves as they start presenting. So we have Dr. Wendalyn. She's an associate professor of pediatric emergency medicine at Emory University and Children's Healthcare of Atlanta. And we have Dr. Moiz Adamji, who is an emergency medicine physician and a fellow of Critical Care College of India, but also a honorary lecturer at MUHAS Emergency Medicine Department. So they'll take us through the talk today, and rest assured, we're going to have a lot to learn. If, as of now, we have muted you, so you cannot speak. But if you have any question, any clarification as of the presentation will be going on, you can just put it on the chat, and we'll be gladly to let our presenters know so that they can get back to you. So welcome all, and let's hear from our two keynote speakers. Dr. Moiz and Dr. Wendy, you are welcome.
Thank you, and good day. Morning here and afternoon for many of you, I understand. And today we'll be talking about congenital heart disease, and particularly presentation of congenital heart disease and management in young infants in the emergency department. So if I could have the next slide, please. The reason this is important is I'm going to give a quick review of the anatomy and physiology we perhaps learned in school. Prior to birth, the fetal circulation is very different than the circulation after delivery. Before birth, all of the oxygenation is via the placenta. So oxygenated blood from the placenta returns to the baby through the umbilical vein, and goes into the heart, and the lungs are mainly bypassed. And excuse me, I'm going to silence something else that's making noise. The lungs are mainly bypassed, and deoxygenated blood returns back to the placenta. And blood is mainly bypassed through the ductus arteriosus, takes much of the the oxygenated blood returning from the placental circulation comes into the right ventricle and out through the pulmonary trunk and into the body. So again, bypassing the lungs. After birth, when the baby takes the first few breaths, the lungs, of course, expand. The baby begins to oxygenate via the lungs. The umbilical vein and arteries close off. And slowly the ductus arteriosus closes. That ductus arteriosus starts to close in the first 24 hours after birth, but may not entirely close until several days after birth. And particularly if infants are sick or hypoxic at all, that might be delayed. And that's why sometimes the presentation of cardiac disease can be delayed after the ductus starts to close. And I will ask you to please close the next slide then. So again, this is just to orient everyone, the normal heart. When we start talking about the various lesions, I find it useful to just remind ourselves of the normal heart. The right atrium taking blue blood or deoxygenated blood from the body into the right ventricle, going out the pulmonary artery, to the lungs, returning from the pulmonary vein with oxygen or red blood into the left atrium, to the left ventricle, and then out into the body. Next slide, please. So why does it matter that we discuss congenital heart disease in the emergency department? It's very common. It's thought to occur in approximately 1% of live births. It is a common cause of neonatal collapse, and the delay in recognition can lead to high mortality. And next slide. And Dr. Moiz is going to take over here.
Okay, good afternoon, everyone. I hope I'm loud and clear. So the lens that we should have when we are in the emergency department is to look at the infant who is in shock, cyanosis, or with respiratory distress as three options. Either they're having a congenital heart disease, either they're having sepsis, or a pulmonary disease. This is important because they are time-critical stabilizations that you must do. The pathophysiology now would be that it's simple. You think of it in this way. If the systemic part of the heart, which sends blood to the rest of the body, is affected, then you will have poor systemic flow and hence a shock and a gray baby. If the pulmonary lesion is present and blood is not going to the pulmonary blood flow or the lungs, then you will have a cyanotic baby or a blue baby. And if you have a hole that is allowing mixing of the blood, the oxygenated and deoxygenated blood, then you might have a presence of a gray baby. Now, when it comes to the classification, right, the classification is quite simple. It's either cyanotic versus acyanotic, blue baby versus not a blue baby. Then there is a ductal dependent. The ductus that Dr. Wendy talked about is important because that is the one which bypasses now the blood and allows blood to go to the systemic circulation and also oxygenation to take place, depending on whether it is a pulmonary lesion or a systemic lesion. And then there is obstructive versus shunt lesions as well. Now, let's talk about acyanotic. Acyanotic is anything that will increase the left to right shunts, for example, ventricular septal defect, atrial septal defect, and patelis ductus arteriosus. The obstructive ones will be your aortic stenosis, your pulmonary stenosis, and your coarctation of aorta. Often these present with congestive heart failure, poor feeding, and tachypnea. These are the ones which will present after 1 month, all right? And they will have congestion as the main issue. So cyanotic lesions, now these are the blue babies, whereby there is decreased blood flow or pulmonary blood flow to the lungs, all right? It could be tetralogy of Fallot when it happens as a mixed lesion, whereby you have a TET spell, and these patients can also present as cyanotic. Tricapsid atresia can also present that way. Increased pulmonary blood flow, like transposition of great arteries or total anomalous pulmonary venous return. Now, how I remember this is I remember the number 1, 2, 3, 4, and 5. All right. 1 is one big vessel. Okay. Truncus arteriosus. 2 is transposition of great arteries because there are two arteries. The aorta changes with the vena cava. All right. 3 is tricapsid because there are tricapsid. There are 3 valves in the tricapsid valve. Atresia. 4 is tetralogy of Fallot because there are 4 conditions which we'll talk about later that are mixed with tetralogy of Fallot. And 5 is 5 letters, which is TAPVR. So those are the lesions that will cause cyanotic problems in your patient. Now, when we talk about ductal dependent lesions, all right, these are the lesions which will require the ductus to be open. And these are especially the ones which will present less than 1 month. All right. If it's a systemic lesion, you will have a baby which goes home well and crashes on day 5 because the ductus closed off. And some of the examples is hypoplastic left heart syndrome, which is meaning basically that the left heart is so small that the right heart now has to take over everything. Critical coarctation of aorta. The aorta is narrowed down to that extent that there is no systemic blood flow, and interrupted aortic arc. So that's a left-sided lesion. So one of the examples is hypoplastic left heart syndrome, like I showed you. Then we have a coarctation of aorta, all right? And then now we move on to the ductal dependent lesion, but now which affects the pulmonary circulation. Like for example, the pulmonary atresia, severe tetralogy of Fallot, severe cyanosis once the PDA closes. And why am I talking about PDA all the time, or am I talking about the ductal dependent, is because if the lesion is ductal dependent and the patient presents less than 1 month, there is time of giving prostaglandin E1, which will remain the ductus open. Right, and more on that after. So I would like Dr. Wendy to take over from this part. Over to you.
Thank you again. So those were introductions to some of the things. And again, we're talking right now about how do we recognize these and different ways to recognize them. Again, having some idea about do we think it's a cardiac lesion at all? And then what to do when we think it is. And after that introduction that Moiz gave, we know that we need to classify them as cyanotic or blue babies when we're not getting enough pulmonary blood flow, or the gray or the shock babies when they're not getting enough systemic flow, or the mixing lesions. So when different ages will also give you a clue. So less than a month is when the ductal dependent congenital left-sided lesions and tetralogy of Fallot tend to show up. And that tends to show up again as the very shocky baby. It can look a lot like sepsis, but the severely critically ill neonate or the very hypoxic neonate. In that 1 to 6 months age, it's less likely to be a ductal dependent lesion. It's more likely to be the mixing lesions, such as the VSD or the PDA, that present as heart failure. And one thing I always tell my residents is to remember that small infants wheezing, yes, it might be bronchiolitis, and especially in bronchiolitis season that we have here in the fall, but wheezing in infants is also a sign of congestive heart failure. So if it's not improving like you think it should, or they're not having viral symptoms and they're not growing well and they're persistently wheezing, it's important to think about heart failure. Next slide, please. So again, looking at the color, thinking about, are they pink, or are they gray and shocky and collapsed, or are they blue? And that's a good pearl, the silent tachypnea, the baby who is breathing fast but looks overall comfortable. You have to think metabolic disease or cardiac disease, as opposed to the wheezing infant or the upper respiratory wheezing of croup or bronchiolitis. But again, I would warn you that also small infants with pulmonary congestion sometimes also wheeze. Next slide. So bedside tests, how do we diagnose these? How do we determine what it is? The hyperoxia test is one good way. And again, this is in particularly the small infants who are hypoxic, and you're trying to decide, is this primary pulmonary disease, such as pneumonia or an infectious process, or is this cardiac? Is to place the infant on 100% oxygen. And even if there's fairly severe lung disease, you should be able to get their oxygen saturations at least into the 80s or low 90%. If the oxygen saturation is staying 50 or 60% despite 100% oxygen, you have to be much more concerned about a cardiac lesion. Checking your pulses. If you don't have good femoral pulses, you have to worry about coarctation of the aorta. Also obstructive lesions, you may have a difference in the brachial and the femoral pulses. And then looking at the oxygen saturation differential. This is a good screening test in newborn infants, looking at the right hand, which is preductal, and one of the legs, which is postductal. If there's a difference in oxygen saturation, it's more than 3%, that is a concern for a red flag. And in the United States, most infants born in hospitals are actually screened by pulse oximetry before they leave the nursery. That's another kind of quick, easy way to determine if you think this is heart disease. And then remember that there are many other causes to newborns being sick, and you always need to think about sepsis, and also hemoglobinopathies and other respiratory diseases can present. But particularly in the neonate that is looking shocky and sick, it's more likely sepsis. I usually, again, tell my trainees to go ahead and test and treat for sepsis, but also be thinking about cardiac, particularly if there's something about it that seems out of the ordinary. Next slide. And Moiz, we were going to talk quickly about tetralogy of the flow, and then we'll talk about TET spells. We already talked about this a little bit. It's one of the most common cyanotic heart diseases, which has 4 different problems: pulmonary stenosis, a VSD, the aorta is sitting over that VSD, and right ventricular hypertrophy. Great, thank you. That's a great picture. So again, you see the large VSD, the aorta, can you all see my thing, is sitting over the VSD. The pulmonary trunk is often narrowed, so they get mixing of blood and shunting, and these patients are often fairly desaturated. And this is the classic boot-shaped heart that they talk about. Chest X-ray can also be helpful, and that is the classic boot-shaped heart of tetralogy of Fallot. And I think Moiz was going to take over and talk about TET spells.
Okay, so these are the common patients we get at our emergency department at Muhimbili. And what's a TET spell, basically? it's simply a situation where blood goes to the systemic circulation at the expense of pulmonary blood flow. All right. So it may be spontaneous and it's due to systemic vascular resistance decreasing. So, for example, if a child is agitated, if the child is in pain or hypovolemic, that's when your blood flow, which is normally from left to right shunt, okay, changes to right to left shunt. All right. Okay. So from left to right, it goes to from sorry, I think I'm confusing myself here. So basically, this is where the flow of blood is reversed, all right? And more blood now does not go to the lungs. And therefore, these kids who are initially normal or they were surviving with the hole that they had, like the VSD and the shunt, but now what happens is that blood flow is decreased, okay, to it doesn't go to the lungs and it directly goes to the systemic circulation, and therefore these patients now have a hypoxia and also they have altered mental status with cyanosis, and because they don't have enough oxygen, they end up having metabolic acidosis as well. So this is what I was talking about, all right, is that there's a reversal of the shunt, this VSD, okay, which allows blood or mixing of blood from the lungs to the systemic circulation. Now that blood, all right, is not going to the systemic circulation. That blood now is not going from the lungs, okay, to the systemic circulation, and therefore you get it's a phenomena called the Essel-Menger syndrome, and this is where you have hypoxia and metabolic acidosis, and these babies present like in shock to us. Now, one pearl that is very important is that if the patient is not in a TET spell, they will have a systolic ejection murmur. But when they are in a TET spell, when the systemic vascular resistance decreases, that murmur disappears. And that's a pearl that you should know about. Now, how do you treat this TET spell? All right, first, keep the baby calm. So first thing which I would do is keep the baby in the mother's lap. All right, that pretty much keeps them calm. Give them 100% oxygen, but be careful now, all right, that you should be confirmed that this is a TET spell. And we will talk about it later, why oxygen sometimes is a drug, and oxygen is a drug and it can be harmful to your babies. So 100% oxygen to allow pulmonary vasodilation so that more blood can also go to the lungs and therefore become oxygenated. When you flex the knee to the chest of an infant who's having a TET spell, you increase the systemic vascular resistance and increase the venous return. All right. Similarly, you want to push forward and give fluid boluses, but be very careful about the fluid boluses as well. 5 to 10 mils per kg is what you need to do, and you need to reassess the patient. Morphine also relaxes the pulmonary infundibulum and therefore allowing more blood to go to the lungs and therefore come out as oxygenated blood. Sometimes we might need vasopressors. I know we don't have this vasopressor in our field, like phenylephrine. We can use norepinephrine, but the downside is that it will cause pulmonary vasoconstriction. And beta blockers to decrease the heart rate and infundibular spasms. And if this patient presents less than 1 month, then you can give prostaglandin E1 to keep the patent ductus arteriosus open and therefore allowing the shunting to take place and the mixing to take place, all right, until definitive repair is suggested. So these are some of the things that we tend to, it mimics a lot of things. It mimics sepsis, it will mimic pneumonia, it will also mimic asthma and bronchiolitis, like we talked about, wheeze, but no bronchodilatory response. So you have to be very you have to be understandable that you need to think about all these things. Like, for example, if the patient does come with signs and symptoms of sepsis, treat like sepsis, but keep in the back of the mind that it could be a congenital heart disease as well. So these are just a reminder of classification and why we said about the classification. We talked about the classification because it gives you a clue. All right, is it cyanotic or not? Ductal dependent or not gives you a clue that should I give prostaglandin E1 to this patient? And obstructive versus shunt is where now you're thinking, should I give fluids? Should I give inotropes? Should I give Lasix? All right, if the patient is overloaded, and that's how you'd go about it. And this is just a reminder of the hyperoxia test. You can give 100% oxygen, or you could do an ABG if you are, but ABG really hurts. So I would go for the 100% oxygen first, 5 to 10 minutes. And if I don't get 100% stats on my, or it doesn't reach the baseline, which is normally there, then I would think about the congenital heart disease. And this is also talked about, okay, but just a reminder. And why was I saying oxygen is a drug? Because look at it in this way. If you give 100% oxygen, all right, you are decreasing the pulmonary vascular resistance. And therefore, what you're doing is that increasing the left to right shunt. So blood is not now going to the lungs, all right? And majority of the blood is, first of all, the blood will not go to, will go from the right, from the left to the right, okay? So basically the left ventricle to the right ventricle, all right? And this will result into systemic output becoming low. And this patient will now present as a shock. It will go into shock. So not all conditions you need to give oxygen 100%. If you're doing the hyperoxia test as well, so give it for 5 minutes, see if your test is positive or negative, and then go down on your oxygen level as well.
Can I say in there, I used to ask our cardiologists how much oxygen to give because for some of the hypoplastic left hearts in particular, they will say that oxygen can be detrimental. And I would always ask them how much, and they would say enough, but not too much. But I finally got them to give me an answer, which is that we would like the saturations to be above 70%. And if you think about it, in gestation, the infant gestates around a pulse ox of around 70%. In the 70s. Much below 70, you become very metabolic acidosis. So for any of these patients, you do not want their oxygen saturations to be 50s or 60s. If you can give them some oxygen and get them into the 70s and you know they're a cardiac patient, that might be where they normally live, and that is probably acceptable. So I try to kind of keep that in my mind.
All right, thank you so much for that. Fluid, we already talked about this, that you need to give aliquots of fluid at 5 to 10 mils per kg and reassess the patient because these patients are at high risk of being overloaded. All right. Now I will allow Dr. Wendy to talk about this because I know that prostaglandin E1 is not really common in our setup, but I'm sure they use it a lot.
So we do. So prostaglandin E1 is a vasodilator, and in particular, it can keep the ductus open and even reopen the ductus in the immediate neonatal period. Now, after a month, it definitely would not be effective. But in the first couple weeks of life, if the baby has been hypoxic, their ductus may have stayed open longer than expected. So if an infant is presenting with what appears to be critical congenital heart disease in the first few weeks of life, you can start prostaglandin E1, and it can be life-saving by reopening that ductus. And depending on whether it's a right or left-sided obstructed lesion, it is either restoring pulmonary blood flow or restoring systemic blood flow. That is the dosing right there. It's a continuous infusion. We usually start on the lower side, the 0.05, and then increase. It can be given through a peripheral IV. You do not need a central line, so it is fine to give it through a peripheral IV. And the side effects are apnea and hypotension and sometimes fever. So you need to be ready to intubate these patients. And we've already spoken about that a lot of these infants you're going to be considering and treating for sepsis. And also, while the drug can cause apnea, just being sick in the newborn period can also cause apnea. So all of these are infants that need to be watched closely because of the risk of apnea. But if you do not have an echocardiogram available and you're highly suspicious of congenital heart disease, it is okay to start the medication until you can get the echocardiogram. Next
So the
slide.
pearl is that we should not wait for the echo. And if you're thinking congenital heart disease, then we can give the prostaglandin E1, right?
Exactly.
All right. Okay. So ABCD, obviously, that's our bread and butter when it comes to emergency medicine. You do that. And SpO2 probe in the right arm and the right leg, so pre and post ductal, all right? And prostaglandin E1 if ductal dependent lesion is suspected. You will do your X-ray, your ECG, and your POCUS. Your POCUS is your bedside ultrasound. So you can do an echo bedside and get your answers there and there. And prepare for escalation. So when these kind of patients come in, I would prepare my intubation kit there. I would have my nurse know that, okay, I might need inotropes. So that's how we would be prepared for such a scenario. And sometimes we would also involve the pediatricians so that they can guide us as well. So this is a case now, all right? And I've given away the answer, but it will give you something to think about, right? So 5-day-old, poor feeding, malted. Imagine lactate 7.5, all right? You have given fluids because you thought it was sepsis, antibiotics, but they're ineffective, all right? Then someone thought about congenital heart disease, so they started prostaglandin E1. Perfusion did improve, and the diagnosis was a critical coarctation of aorta, all right? So teaching point here is that if a baby comes in shock at day 5, think of that ductal dependent lesion and think of congenital heart disease, all right? This is case number 2. A 3-day-old, their stats are 60. Look at that. Lungs are clear. All right, that's another pearl that you should think about when you think about congenital heart disease. If they present very early, the chest will usually be clear. Now, the chest X-ray shows egg on a string. Okay, there's no improvement with 100% oxygen. That's the hyperoxia test that we talked about. And this diagnosis was transposition of great arteries. Here is also, you would want to think about if it's less than 1 month, the patient presents to you with this kind of a ductal dependent lesion, then prostaglandin E1 will help. And then urgent balloon arterial septostomy is what you do. The pearl is that the failure of hyperoxia test equals to congenital heart disease. Now, let me show you the egg on the string, just have your imagination ready. Now think of this as an egg on the string. Okay, this is the string and this is the egg. Okay, so that's for transposition of great arteries. Now, Dr. Wendy, can you take this?
I will. This is a 3-week-old who is breathing hard and wheezy, but no response to suctioning and bronchodilators. And this chest X-ray shows a snowman sign, or very hazy and enlarged heart, which I think we'll show in a minute. And this one was total anomalous pulmonary venous return, which is an obstructive phenomenon where the blood is obstructed from re-entering the heart, causing pulmonary congestion. So the pearl here is, again, wheezing that is not typical of bronchiolitis. You need to consider cardiac points. And the other pearl in this, the child might have had an enlarged liver, that might have been helpful as well. But that is the hazy lungs, and they say the snowman sign where the atria are very distended there, the pulmonary veins. And Moiz is going to talk about POCUS, I think, in the ED.
All right, POCUS is something that is dear and near to my life and my heart, because I have made some major decisions when it comes to my patients. And even in this small little people that we call them infants and neonates, you can do a POCUS, okay? So let's say if the right ventricle is larger than the left ventricle, right? Then the right side is overloaded. Now you're thinking of TOF, transposition of great arteries, and those cyanotic lesions, okay? If the LV is collapsed, then you think about systemic obstructive lesions, right? Once you have ruled out your shock and sepsis and whatnot. You can even see pericardial effusion when you can exclude them, and it's rapid, it's repeatable, and it's bedside friendly. So imagine doing an X-ray all over every now and then. You can just pretty much use your ultrasound. Now, this is, I know that we have been talking about this over and over again because I see people not doing it, right? It's taking 2 saturation probes on the right-hand side, right hand, right leg, and the difference is a good screening tool. So this is for the pediatricians as well, who are seeing neonates more than us, and simple, cheap, and high-yield ED tests that you can use. So some of the, we already talked about this. So this is a transposition of great artery. This X-ray, the boot shaped, remember, TOF, and this X-ray, the snowman, the 5-letter word, right? The total anomalous uh, venous return. And ECG pearls, now I'm not really a fan of ECG in kids, but when you have to do it, you will find signs like right ventricular hypertrophy, left ventricular hypertrophy, incoarctation of aorta, extreme axis deviation, and it's more about using of patterns rather than being perfect and saying, oh, you know what, yes, this is RVH, so this must be tough. No, it's
I find
combination of
this,
everything.
yeah,
Yeah.
I find this
Yes. Yes.
difficult too. It's hard to diagnose congenital heart disease on ECG. It's good to get and make sure there's not a dysrhythmia, is what I would say if you're suspected of
Yeah.
cardiac disease.
All right. So again, when are you going to suspect congenital heart disease? You're thinking about an afebrile shock patient, negative cultures, poor antibiotic response, hepatomegaly or murmur present. This is when you think about the heart and not just sepsis. Okay. And majority of the times it will be like a tachypnic kid with desaturation, and people are like, oh, it's pneumonia, doc. Trust me, pneumonia. And chest X-ray is clear. That's where you see those signs of boot-shaped or snowman or egg on the string. And oxygen stat doesn't improve. You might have a gallop murmur or a weak pulse present in such a situation. Your ED checklist is going to be the same: secure the airway, but anticipate apnea. If you're giving, especially when you're giving prostaglandin E1, place 2 probes. Avoid high oxygen. We already talked about this. Avoid large fluid boluses. And early cardiology call. So it's something that you should talk to your pediatric cardiologist or even pediatric cardiothoracic surgeons. And they would probably help you out because of the number of times they've seen these patients. For us, it's JKCI. Advanced management, obviously, I mean, it's the same thing. If the patient presents with cardiogenic shock, you're going to start with dobutamine or milrinone. And you want to avoid acidosis because acidosis increases the pulmonary vascular resistance. Okay. Similarly, hypoxia does the same, and hypercapnia does the same. So you have to avoid those things. Intubation, if you give prostaglandin E1 and the patient goes into apnea, so you intubate the patient. And it's all about the trends in the ED or any, even in the critical care. So you think about the lactate trend for perfusion. Critical pitfalls, we've talked about this, that you can mistake it as sepsis, asthma, or pneumonia, or simple pneumonia, and you might start over-oxygenating your patient and worsen the instability. You might delay PGA1 because you are waiting for an echo by a pediatric cardiologist. Overloading fluids in a patient with congenital heart disease will, because they have congenital, they have fluid overload. So those are my pearls. And prognosis and disposition. Many lesions require surgery or repair, and I think Dr. Wendy will talk about this more. ED role is to bridge to definitive care, and survival depends on your stabilization. So the pearl is any neonate in shock, unresponsive to fluid, is a congenital heart disease patient until proven otherwise. Now, I think you can take over this case, Dr. Wendy.
I just have a couple of thoughts. Yes, most of these ultimately do require treatment in a cardiac center. The most common congenital heart disease is a ventricular septal defect. We didn't really cover that. That's one that might present after a month of age with wheezing and signs of congestive heart failure and overcirculation. Many of those infants are treated medically here in our setting until they are about a year of age, can be safely operated on, and some will close on their own. So that's one group that could potentially be medically managed. They often will need Lasix or other treatment of their heart management, and sometimes need supplemental feedings to grow. Likewise, the atrial septal defects often are not operated on until later. But most of the other conditions do need to be operated on fairly early. The hypoplastic left hearts are done in a series of operative procedures. Tetralogy of Fallot is usually done at one procedure around 4 to 6 months of age. So the infants, again, are sort of stabilized with their heart failure until they're big enough to have the surgery. Once, if they start having TET spells, is usually an indication to go ahead and operate on them, because TET spells can be fatal and can certainly be very detrimental to the infant. So I think this one was a hypoplastic left heart, profound cyanosis, oxygen saturation of 50%. I think we talked about you would like to get your saturations at least 70%. So yes, I would give oxygen. It also depends on where in their management are these patients. For the hypoplastic left hearts, go through a very complex, here at our center, series of repairs, where a new aorta is created and then a new systemic to pulmonary shunt, essentially a sort of synthetic ductus is made, or sometimes the ductus itself is stented open. And then those patients, their entire pulmonary circulation is dependent on a very small piece of shunt, like a few millimeters wide. So they're very delicate. If they're if they become dehydrated, they often become profoundly hypoxic and distressed. So gentle fluid resuscitation. Oxygen can be detrimental in them because it can cause pulmonary vasodilation, and the blood will primarily go to the lungs and bypass the systemic circulation and worsen the shock. So I would say I would try to avoid 100% oxygen and start sort of slowly and work up. A lot of times these small infants do well with some flow, some oxygen or air flow in their noses. It gives them almost some CPAP, some distending pressure, as well as some reasons to breathe. So sometimes we'll put them on a nasal cannula and start from there. And if you can blend it to 30 or 40 or 50% oxygen, if you cannot, just doing a couple liters of nasal cannula.
All right. So this one is a 7-day-old, afebrile, shock, poor perfusion.
That's a tough.
We have talked about our approach, which is, does anyone want to try this? You can unmute and try this. We use that formula of age, color, and hypothesis, and I will give you the answers. Tough crowd.
It is. If I was to answer this question, I would say whichever one I could get first, but I would probably do both.
All right. So basically, the approach would be the same, right? A, B, C, D, right? You would give fluids, obviously, but in this kind of a patient who is not improving oxygen and is crashing on you, the fluid will help momentarily, but you might want to give the prostaglandin E1 in such a case.
That might be a patient I gave a 10 milliliter per kilogram bolus while asking someone to get the prostaglandins.
Yeah, so simultaneously. Similarly, this question, neonate shock, lactate, 8 negative cultures, best ED intervention. So obviously this question is rigged a bit, but you can say that, okay, 20 mils per kg, would you give a neonate or an infant 20 mils per kg? No, right? And then would you start antibiotics just because you saw a patient, a neonate in shock and negative cultures? No. Intubate immediately, maybe you would wait, right? So the best answer is prostaglandin E1 in such a case scenario. I'll make sure this question comes somewhere. All right. Last one is egg on the string heart on X-ray, and the patient is cyanotic. The best next step. So again, I'm trying to force or emphasize and make people say that, okay, because I had a recent case of a similar neonate like that. Day 1 is okay. Day 3 crashes and comes to a hospital blue. We give them oxygen and the color starts changing to pink, all right? But the oxygen is not improving, right? So we did give oxygen, but the best next step in such a kind of a situation would be a prostaglandin E1, which unfortunately we did not have, and we lost the kid. So summary is that congenital heart disease mimics sepsis, respiratory disease in ED. It recognizes patterns, and you need to recognize the pattern, and you need to act fast. Stabilization is by prostaglandin E1, cautious, oxygen and fluid, and early echo. ED saves lives by buying time. So we are the bridge. So if we don't provide a good support of bridge, then our patients will never make it to cardiothoracic surgery. That's from us.
We are
Thank you
happy
so
to
much.
take
Thank you
questions.
very much, Dr. Moiz and Dr. Wendy. So there are basically two questions that Dr. Nisa and Dr. Deus have asked, which looks similar. Okay, Dr. Wendy and Dr. Moiz, could you see the questions, or let me just post them back again so that you can see and probably respond?
Moiz, are you able to put the picture of the tetralogy of Fallot back up? I think it's easier to explain that answer with the picture, like the diagram of tetralogy of Fallot. Because I think the question is what medications work. I think one more down. Yes. Oh, no, one back up, right there. I think that it's no, back to the one. There's tetralogy of Fallot. I think the answer, again, all of these patients have some cyanosis because they have the large mixing. Often the mixing is somewhat balanced and they're doing okay. They might have oxygen saturations in the 80s, but they're fairly stable. If they have fever or dehydration, or some sort of other illness, their systemic vascular resistance may drop. And then more blood is flowing to the systemic side and not going, so out the left ventricle and out the aorta, and not going to the lungs. So they have decreased pulmonary blood flow. So they become more hypoxic. You may lose the murmur because there's less shunting, and they become more blue, and they become more cyanotic, and they become acidotic because they are hypoxic. So the interventions are then to get more blood through the pulmonary circulation, and you can do that one just by calming an agitated patient. Anytime a patient's crying, a baby's crying, they increase their intrathoracic pressure and their pulmonary pressure. So calming them. Morphine will help relax that sometimes too. Giving them oxygen will vasodilate the pulmonary bed and will bring more oxygen to the lungs. So that will help get them oxygenating better. So these patients, it's okay to give oxygen to. You want them to have better pulmonary flow if they're having a TET spell. Giving some fluid bolus will also increase their systemic vascular resistance on their systemic side, and that will force more blood through into the lungs as well. And also, as Moiz said, putting their knees to their chest increases the vascular resistance and forces more blood from the left side to the right side and through the pulmonary bed. Does that answer the question? Oh, nitroglycerin nebulization. I have never heard of doing that, I'm going to be honest with you.
So in terms of the adult literature, like, when you have those the princess heart, the right ventricle heart, which is failing, there are some few small studies, but not really any systematic meta-analysis or anything of so. But you can give nebulized nitroglycerin, and somehow it helps with the pulmonary vasodilation. So, but it's still like it's more of an expert opinion. So I would not recommend it.
I've not heard of that before.
Not heard of that in neonates or congenital heart disease patient.
And I see the question about was it fluid or PG1? Decided was probably both. I think in reality, as you're seeing an infant with shock or any patient with shock, I think all of our first thought will always be to give fluids because that's our first treatment of shock. So I would say as you obtain vascular access, I think even if you're considering congenital heart disease, giving a 10 milliliter per kilogram bolus is probably okay. But if you're suspicious of congenital heart disease, more boluses are not going to make it better. You should reach for your prostaglandins as soon as possible.
So Leonard Stefan has a question, and he's saying, is there a role of nitrous oxide in tetralogy of Fallot?
Again, it's not, I've seen it gets used in our ICU settings that often patients are intubated. They will do nitrous oxide for pulmonary hypertension. I don't know that it's ever been given in tetralogy of Fallot because they don't have pulmonary vascular hypertension so much as an infundibular stenosis. So I don't know the answer. I guess in theoretically it would work. I've not heard of it being used.
And I had a question actually, and maybe it would benefit all the. So you have a tetralogy of Fallot patient, or you have any patient who has cyanotic heart disease, and most of the times we know that cyanotic heart disease patients have right-sided heart failure. How would you intubate such patients? What precautions would you take while intubating such patients?
Sure, these are very difficult patients to intubate. Um, because unfortunately they tend to have cardiac arrests when we intubate them. I think we're all very rightfully scared of intubating heart failure patients. First is to optimize them as much as you can beforehand. So again, I usually put them on some nasal cannula to try to oxygenate them as best as possible, realizing you may not get normal saturations. I use ketamine to intubate, and our cardiac doctors like ketamine as well, because it maintains your blood pressure, it maintains your cardiac output, as opposed to other medications which might decrease your cardiac output. So I use ketamine and a paralytic usually, to intubate them. And then once you've intubated them, again, don't try to aim for a normal oxygen saturation and don't hyperventilate them. You want to aim for normal carbia. And again, if you can get the oxygen saturations to the 70s or 80s, you're doing well. I also, for young infants, I give a dose of atropine prior to intubating them, because I don't want them to get bradycardic from vagal stimulation, because once they become bradycardic, it can be very difficult to get them not bradycardic again. So I usually will give atropine while I'm getting ready for intubation. We'll intubate with ketamine. And I usually have a code dose of epinephrine drawn up and at the bedside in case I have difficulties.
So is it like, do we have push dose presses for pediatric patients?
Push dose epinephrine would be a fine way to do that too. I generally have a full code dose drawn up. I'd be interested if Brittany has a different thing if she wants to take it. I usually have that drawn up and ready to go, and if they become bradycardic, I will go ahead and give it.
All right. So there was a so in terms of it, there was a question in my mind, and now I don't know where it has gone. Maybe I'm free. I think I am. It's late afternoon, and I had just my lunch at 2, so I'm a bit sleepy. But yeah, so I'm free. Take over, man.
Okay, thank you very much, Dr. Moiz and Dr. Wendy, for a very nice and elaborative presentation. And I'd also like to thank all the participants who have joined in, and I'm sure they have quite learned a lot, and probably they have more questions. We are still right on time.
Oh, yeah.
Just a few things to highlight to the participants. This is a CPD accredited activity. So in order for you to have your CPDs, just make sure before you leave, you have written your NCT number and your name on the chat so that later on we'll claim the CPD points for you. But as well as I said, this is our 10th Pediatric Emergency Medicine lecture series, and we have been conducting this every month. And for those that are joining us for the first time, I would just like to let you know that we also have all the PEM lecture series recorded for you, and you can access them on our YouTube channel. And I'm just going to share the link on the chat so that if you want to get back to any of the presentations that either you missed or you want to just remind yourself and get the concepts, just go to the link and you'll have all the presentation that we have been doing. So I'd like to welcome, if there's anyone with any questions, you can just either unmute or put it on the chat, as we still have 12 minutes.
I know what my question was. I remembered. Is there any JKCI people in this? If there is, I wanted to ask you, do you guys have prostaglandin E1? And is it readily available? It's just us.
I believe the question was which facilities have prostaglandin available?
Yeah, that's the question, because I know for sure. Maybe if Aga Khan has one, and if there is someone from Aga Khan, it's normally they do have such medications. All right, I guess we will
Oh,
find out.
there's an answer. Someone says prostaglandin is available.
Okay, that was pretty much it from my side.
I have a question. Is prenatal echocardiogram at all common, or are many of these infants diagnosed after birth?
Um, so they do. As far as I know, they do those anomaly scans,
Hmm.
but I don't think anyone is diagnosed like that. Maybe our obs and gyn fellows or pediatricians who are closely working with them would know.
I see another question. Is there prenatal echo is done at JKCI? Excellent.
All right.
As for the question of blood transfusions, not routinely, no. Most of these infants, if they have chronic hypoxia, are actually polycythemic. So I don't think if they were anemic for some reason, some unrelated reason, or had hemorrhage, then sure. But in general, no, I don't believe there's a role for transfusion. Oh, more prenatal echo. Nice. I don't think there's any oral prostaglandin. I believe it needs to be a continuous infusion to keep the ductus open. And I suspect there would be too much hepatic degradation. I've never heard of it given orally.
I know this is an emergency medicine talk, but how long do you give the infusion of prostaglandin?
You keep
Like,
it going until they're surgically repaired, or
okay, so
until you have an echo that shows it is not heart disease. So I think if you know or highly suspect that it is ductal dependent heart disease, you start the prostaglandin and you continue it until they've been surgically repaired.
so you had cases whereby maybe a doctor was thinking maybe congenital heart disease, but it was not, and they gave prostaglandin. So would you advocate that kind of a practice that you can give if you're
Yes,
thinking about
I'll
it?
tell you a case. I took a phone call from one of our not pediatric facilities, and they had I believe it was a 4-day-old infant who had come in because he wasn't feeding well and he was profoundly cyanotic with saturations in the 50s, um, and everything else fairly normal. And we got our cardiac intensivist on the phone and we talked through that. Yes, we should start prostaglandin. That they would sort out, later, and can always. I think his answer was we can always turn it off. As we talked about, there are the potential side effects of apnea. But again, very sick newborns are going to have apnea anyway, is my feeling about it, and you need to be prepared to take over for them. So there's very little downside if you know or strongly suspect in turning it and starting it, and then again, it would need to be continued until. Oh, in South Africa, they use oral prostaglandins. How interesting.
Yeah, and there was a question by Yese. What will the priority?
Mm,
What will be the priority if the infant is found to have arrhythmia and a
yes.
TET spell?
I think you have to correct the arrhythmia.
Yeah,
Um,
definitely, definitely.
Particularly, the most common arrhythmia that I think infants with congenital heart disease would have would be supraventricular tachycardia, which over time um, they develop worsening heart failure. So I think you would need to address and treat the supraventricular tachycardia. Obviously, if it's ventricular tachycardia or one of the more quickly lethal arrhythmias, of course, you would need to address that also.
All right. So
I'm
she's
going to
just
need to look
giving
up,
information.
research the South
Yeah,
African oral prostaglandins. That's very interesting.
Yeah. And then she's saying also, I think there is a fetal maternal specialist who does ultrasound for fetal anomaly, including echo. All right. Okay, great to know there is prenatal echo and neonates to get the. I mean, you see now, this is the power of doing CMEs. You get to know. Great. Now, Humphrey, I think we are having
Yes.
those awkward
Okay.
silence
So
moments. So we
yeah,
should
thank you.
end.
Thank you very much. And thank you for the participants for being very interactive. And this has been a very good session whereby the participants have really interacted. And I'm sure we are quite learning a lot from all these interactions and questions and answers. And I know there's more that people will like to ask. But then we only have 5 minutes left on our presentation. If there's any other burning questions, yes, you can just type it in. If not, I'll just remind you to make sure that you have written your Medical Council of Tanganyika registration number on the chat so that we'll then have to follow up for your CPD. Then just last, I'll say this will be maybe the last question. There's a question from Michael. When would intubation be considered in a refractory test spell? And how do ventilation parameters affect cardiac output in this context?
My answer would be if their mental status is deteriorating, I believe, or they were having apnea, or you could not get the oxygen saturations up with the other interventions would be my answer. Moiz, do you have a different answer?
No, I would agree with you.
Ventilation parameters. Whew, again, you do not want them to be hypercarbic because but you do not want to be hypocar. I think you would go for normal cardio, so normal ventilation parameters. And again, I think you could give as much oxygen as it took to get their saturations up and then wean it down.
Okay, great. So I'll say thank you all. Thank you, Dr. Wendalyn and Dr. Moiz, for such wonderful presentation. And we'll now officially close our presentation for today and just leave the chat open for those that have not written their registration numbers to keep on writing. But I'll just like to inform Dr. Maria Ndinoshisho, kindly contact Dr. Helga Naburi. She has written an email on the chat as she will really wish to have access to the prostaglandin E1. She's a neonatologist, and I'm sure she'll really be happy to connect and get more information as we treat all our sick neonates. And she has written an email on the chat, so kindly connect. We have officially closed our presentation. We'll just leave the chat open until 4 so that for those that have not written to finish up writing. Thank you all. Have a good evening and a good morning to our colleagues in the US.
Thank you all.
Thank you.